These are my disclosures, none of which relates to anything associated with TR, but you should be aware that I do serve on scientific advisory boards.
Seeing your slides.
We have Dr. Leon's slides up
Oh,
there.
sorry.
Yeah.
Could you put the slides up?
Yeah. Yeah.
Terrific, thank you.
Thank you.
Much better. Okay. As Steve Bowling said, if you don't put some version of this obligatory slide up in a TR talk, then you're obviously remiss. It points to the fact that this is a disease of very significant prevalence both in Europe and the United States, and the number of surgical procedures is a tiny fraction of that. So clearly we're missing the boat, and if we say that severe TR is bad, for the most part, we're really not treating severe TR in the vast majority of patients with any definitive treatment. And I'm not even sure that I agree that surgery is a definitive treatment. Second point is, and Becky's well qualified to speak about this, the natural history of TR is clearly associated with a poor prognosis, but the data really is only now becoming more clear with more studies from more groups. We go back to the old VA study that NAF did 15 years ago, and even after adjusting for age, left ventricular ejection fraction, IVC size, RV function, and PA pressures, there clearly is a relationship between the severity of TR and prognosis. So severe TR is a bad actor, but we're talking about something that declares itself over the course of several years. A little bit different than aortic stenosis. Now, this is an all-comers natural history study. Now, if we scroll forward and look at the changes in national trends with respect to surgery, you've seen this slide as well. We're seeing an increase in the amount of surgery being done for TR, but we're not seeing any better surgical outcomes in general from the standpoint of procedural mortality, which still remains very high at 9%. And this tends to mitigate and affect all of our opinions about who we should be treating. And treatment of isolated TR using surgery, as Steve said earlier, is one of the worst operations that we do, and it's associated with a high mortality, and that hasn't changed. So as we talk about designing clinical trials, we have some real challenges. I don't believe the tricuspid valve is forgotten any longer, but we still don't know enough about it, the natural history of TR. The fact that late symptom presentation makes it difficult to design clinical trials, that medical therapy is of unproven benefit, and that surgery is only performed in the minority of patients due to the high mortality we discussed. We've talked about the fact that imaging is, again, a challenge because either the transthoracic or the transesophageal echo imaging techniques are difficult for both diagnosis and therapy guidance, and that's compounded by the fact that the tricuspid, the TR is so volume dependent, and any change in volume status can significantly affect your assessment of TR severity. Being able to identify irreversible RV dysfunction is also problematic. We don't have a simple, clear trigger that we can point to when the RV has gotten so dysfunctional that further treatment is not going to benefit the patient. The timing of treatment now is highly controversial. We'll get into that in a moment. And the safety and clinical value of transcatheter therapies are still in what I would describe as an exploratory phase, even though we've begun to enter pivotal clinical trials. Becky has shown this slide, and this is just an example of the 18 different TR transcatheter devices that have been used in patients. So you're talking about a vast array of different devices with different effects, all of which are intended to reduce or eliminate TR, the orthotopic valve replacement being the most aggressive from the standpoint of eliminating TR. I put this slide together several years ago to help me understand what some of the clinical trial pathways should look like. Right now, the patients we're seeing are the patients with the severest degrees of TR. They're very symptomatic, as Scott said. They have edema, they have ascites, they have hepatic dysfunction, they have cardiorenal syndrome, they're diuretic unresponsive, they have marked fatigue more than shortness of breath. And with this right heart failure and RV dysfunction, I call this phase 1 patient that we're currently seeing in most of the early feasibility studies. That's a difficult group to base an approval indication on and a clinical trial. So we are now beginning to evolve into a next phase where, of course, the TR is still severe, that the symptoms are a little bit less severe, and we're seeing less degrees of RV dysfunction. And even though these are not such symptomatic patients, they may be class 2 from the standpoint of functional capacity, we think that they are appropriate candidates and should be included in some of the clinical trials pathways that we'll be discussing. Ultimately, and I think the real value would be what our surgeons are doing, which is to say if you identify clear, severe TR, maybe plus another marker that suggests that these patients won't do well over a period of time, in the absence of symptoms, we should be treating their tricuspid valve using a transcatheter device. The problem here is that we've got to prove that these therapies are safe. We've got to demonstrate first that we can get consistent and long-standing TR reduction before we apply this in a severe TR asymptomatic group for prevention of future clinical deleterious outcomes and a change in either survival or late hospitalizations. These are complex trials that will involve a huge number of patients and delayed follow-up, which is why I don't think we're ready for that phase 3 patient in terms of clinical trials. But that is the pot of gold, and that's, I think, where you want to be several years from now. Another point to recognize, and this is a slide straight out of the FDA, which is that when we talk about designing a clinical trial, we're talking about benefit risk determination and mitigation. And there are many issues in TR patients that have to be considered. One is this whole issue of the unmet need of managing a severe TR patient who's highly symptomatic without therapy options. Some respect for patient preference. So many times patients are willing to accept risk or invasiveness for the potential of an increased benefit, and they're willing to trade benefit for lower risks and less invasiveness. So rather than do surgery with a high risk, many people are willing to try a transcatheter technique, even if we don't know that the magnitude of TR reduction and the benefits are there yet. So it's this constant tension between risk and benefit, managing unmet needs, and also patient preferences. So as we design trials, of course, we have to define what the study population is, and that is inclusion and exclusion criteria. We have to determine what control therapies are going to be applied, assuming these are going to be randomized trials, surgery, or some form of guideline-directed or even non-guideline-directed medical therapy. This is difficult in this space. We've got to define what the primary and secondary endpoints are for both efficacy and safety. And then the study design itself. What are the methodologies that we're going to apply? How many patients? What is the study duration? And then we have to rigorously execute a clinical trial. Well, we're not going to have time to go through all of these, but I'm going to focus on the endpoints, the primary and secondary endpoints that would be most meaningful in TR trials as we look forward to studies and are designing trials today. And I've summarized them as follows. Obviously, mortality, heart failure hospitalizations for sure. We've been talking about TR reduction. A robust clinical endpoint that's been used in many heart failure trials is 6-minute walk distance, and we'll talk about some of the advantages and disadvantages. There's been a lot of interest recently in functional improvement, including quality of life measures, and many other clinical endpoints and biomarkers. Becky's mentioned some that so far have not resonated. They have not been validated for right heart failure, and it would be difficult to apply them in clinical trials in other than a secondary endpoint basis to simply collect measures and to use these potentially in the future. And we will spend some time talking about composite endpoints because that's the direction that we're going to be going in with most of the clinical trials. So we'll start with mortality. Clearly, a difference in mortality is the most compelling practice-changing clinical endpoint. If you had a simple all-cause mortality head count, then that would define a therapy as being substantial and would change your clinical practice. But it's very difficult to power a clinical trial in TR solely on a mortality endpoint, as these events accumulate very slowly over time. You need large sample sizes, and that depends on the magnitude of the treatment effect. So when we go back and look at mortality benefits of therapies for heart failure and reduced ejection fraction, we have multiple classes of drugs that have demonstrated impressive decreased mortality, thousands of patients in these randomized trials with effects as low as 16% and as high as 37%. And this really defined what guideline-directed medical therapy was for HFrEF. When you superimpose COAPT on top of that, you see a very pronounced additional 42% reduction in mortality. And I think it's one of the things that really caused people to believe that, yes, that endpoint in this clinical trial, even though it wasn't the primary endpoint, certainly changes the way you think about clinical practice. Now, even in COAPT, when you look at that endpoint, remember that COAPT was meant to be a 2-year study. All patients had to have at least 1 year follow-up. If you look at 12 months in the COAPT trial, a study that took 5.6 years to enroll and involved over 600 patients, at 12 months, there would be no mortality benefit. So you really have to wait longer to see a change in mortality. And to be perfectly honest, most investigators and sponsors are impatient and don't want to wait 2 years, 3 years, 5 years for a mortality endpoint. So even though you'll begin to see some trends, you saw nothing at 6 months. At 12 months, you begin to see these curves diverge. It'll be interesting to see what the 3-year results are in COAPT to TCT next year. So that's the problem, or one of the main problems with mortality as an endpoint. You must also consider cardiovascular versus all-cause mortality, because a lot of these patients have concomitant disease, mitral valve disease, coronary disease, many other things. The different stages and morphologic subtypes of TR, the competing risk of death and the impact on other endpoints, and the association of improved mortality in TR reduction. If you can show an association of improved mortality and TR reduction, then I think it strengthens the finding that even though you don't have a statistically significant mortality benefit, that you're certainly moving in a concordant fashion. Now, I stole this slide from Becky and modified it slightly, but I mean, this shows you that there are multiple trials now showing that with varying morphologies of TR, the TR severity and mortality are linked. But again, I want to point out that the ordinate on these trials is years. I mean, some of these trials go out to as long as 5, 6, 10 years. So, and to me, one of the most interesting studies is the more recent Topilsky study from Mayo Clinic, showing that for isolated TR, clearly the severity of the TR does have an impact on mortality. So you would normally imagine that if you can reduce the TR severity at an early enough stage, that you would impact clinical outcomes in patients. There are some preliminary data that suggests that transcatheter TR therapy is associated with improved survival, but these are registries, these are propensity matched series, they're fairly early, so mortality should definitely be included as an important clinical endpoint in future clinical trials. And I'll point to the TriValve International Registry. I've got to give Maurizio Taramasso a lot of credit for the effort that he's taken in this. And this is 312 high-risk patients with severe TR at 18 centers. It's a small group of patients. That number now has exploded. There are thousands of patients with TR that have been studied, and this was published last year. And if you define procedure success as the patient being alive, having a successful implant, and a reduction of TR to 2+ or less, there was an impressive relationship between procedural success and survival. So if you can improve the TR with a transcatheter technique, and this is a relatively all-comer population, then there is a potential survival benefit. So, you know, this is non-controlled studies, but it certainly it pushes you to think that we're moving in the right direction. What about heart failure hospitalizations? Remember, this was the sole primary endpoint of the COAPT trial. This has now been rapidly integrated as a standard endpoint for heart failure trials and for MR trials. It's certainly clinically meaningful in a rigorous clinical trial. Many different caveats. It's got to be carefully adjudicated by a CEC with accepted definitions. We talked about stable medical therapy, less appropriate in TR than it is in MR, but there should be some reference to a stable medical therapy baseline, and I certainly agree we shouldn't be allowing changes in medical therapy during the course of the clinical trial unless they're clinically indicated for various reasons. In a selected population, you should expect an earlier treatment effect with heart failure hospitalizations than you would with mortality. And that effect should be expressed usually in months. Now, that's if you have a selected population of patients that are symptomatic enough where they've had previous hospitalizations perhaps in the last year or two. You should also begin considering the surrogates of what we call heart failure hospitalizations, such as ED visits and what some people call in the heart failure lexicon intensification of medications. That's clearly has to be adjudicated. And it's nice to be able to show that the improvement in heart failure hospitalizations are associated with TR reduction. Going back to COAPT again, you see that the divergence of the all hospitalization curves for MitraClip versus GDMT alone was almost immediate. So here you can begin to see some earlier effects. So that is encouraging, and we expect that in TR trials we should be able to demonstrate that in a severely symptomatic patient population. Now, it's also interesting because many of these patients don't present to hospitals and are admitted, and in various institutions the admission thresholds are different. This is from the Paradigm trial, which is a heart failure reduced EF trial with Entresto. It's a large study, 8,000 patients, published a few years ago in Circulation, that a dedicated heart failure hospitalization was not very much different than an ED visit with heart failure or even intensification of therapy with strict definitions as adjudicated by a CEC. So I think you need to have a slightly broader classification of what heart failure hospitalizations and surrogate for hospitalization are when you use this as an endpoint. This was also a very important observation from COAPT because they demonstrated that if you reduced the MR, either in the patients who were on guideline-directed therapy or, of course, with MitraClip, if you had reduced it below a certain threshold, that was meaningfully impactful from the standpoint of reducing the endpoint of death or heart failure hospitalization. So if you can show that association with TR reduction and an improvement in clinical benefit, it simply strengthens the finding. It's important also to capture multiple hospitalizations. Many people use this endpoint in combination with mortality, so it's death or hospitalizations. And we all have to recognize, as we've discussed, that right is different than left heart failure. The signs and symptoms have to be carefully adjudicated by a CEC. And the presence of congestive hepatopathy, cardiorenal syndrome, diuretic dose and responsiveness, ascites edema are all things that we're going to be looking at as we define these heart failure hospitalizations. We've talked about TR reduction as being an endpoint. I frankly believe that TR reduction by echo should be a necessary a requisite of a therapy that's meant to reduce TR. But I don't think it's sufficient as a primary endpoint. So I think it should be a secondary endpoint, and we can discuss and debate whether or not it should be powered. I would make it a soft-powered endpoint. We are not asking for too much, but if you can achieve even a modest threshold of TR reduction over the course of a several hundred patient clinical trial, I have to scratch my head. It's nice to also see that the TR reduction is sustained. That had been an issue with surgical TR therapy, so I think that's an important consideration as well. The issue of echo measures of TR severity, Becky has covered. The extended grading system, I think, needs to be applied. An echo core lab is going to be mandatory. And complete resolution of TR, unlike MR, and I would disagree with Steve Bowling, you can leave some TR behind. I don't think you have to eliminate the TR because I think you can achieve a significant clinical benefit even with TR reduction as opposed to TR elimination with a transcatheter therapy. The REDUCE FMR study was an interesting trial because they used as a primary endpoint, it was a sham-controlled study in patients with functional MR. They used regurgitant volume as the primary endpoint. There were a lot of issues with this trial, and a lot of them had to do with the echo interpretation, grading the MR severity, but it's very powerful in a randomized trial, and this is with the Carillon device, which is an indirect mitral annuloplasty device. They showed a very significant difference between one group versus the other in a sham-controlled blinded study. And so showing MR or TR reduction, I think, does have importance in a clinical trial. Becky has shown this, which is her advanced grading scheme. You know, nothing is perfect, but certainly it gives us greater clarity in terms of the severest degrees of TR. And this is unlike MR because we do see so many patients that go beyond the classic definition of just severe. I also think that it's important when we look at some of the clinical trials, this is a point-to-point analysis that we presented about a year ago at TCT. It's a 30-day outcome from the former trial, and Sushil Kadali presented this. I mean, you can see by either PISA-EROA or 2D, 3D EROA that there is a significant group difference. But even at 30 days, most of these patients had at least moderate TR, and some had severe, and some even had massive. So, and there was very significant improvement and clinical benefit. So you don't have to eliminate the TR in order to achieve clinical benefit. And in the TRI-REPAIR cardioband study, the same thing was observed. Very significant changes at 30 days as determined by an echo core lab, yet these patients did well. Well, how do we incorporate 6-minute walk distance? This has been extensively studied now in heart failure trials. It's previously been used as what some people call a soft primary endpoint. It's somewhat more problematic in right heart failure TR studies due to the variability from patient to patient. Methodology is very important. You've got to guard against training effects. You've got to exclude low and high baseline performers. Many people still argue about continuous versus dichotomous changes from baseline. CPET may be better, but it's very difficult to integrate in clinical trials, and it's commonly used in combination with other functional endpoints and not by itself. There's been a clear transition from simplistic functional indices like New York Heart Association class to more quantitative quality of life parameters like KCCQ scores. It is interesting that even though we're using these ubiquitously now, that's the Kansas City Cardiomyopathy Questionnaire score, the overall score, it's not been validated or applied in right heart failure studies previously. So we simply extrapolated this from a lot of the heart failure reduced EF studies that have been done on the left side. But the early feasibility studies in severe TR patients suggest a consistent improvement associated with changes in other functional measures and a reduction in TR severity. So we think that this is a more quantitative and more meaningful functional endpoint to look at. It's certainly been growing in popularity as a meaningful secondary endpoint and is commonly used now in combination with other functional and clinical endpoints. So from that former study, once again, if on the left is New York Heart Association class, on the right is 6-minute walk distance and KCCQ scores, you can see clearly that there's a consistent benefit, and we were struck a 24-point improvement in a KCCQ score at 30 days is striking. It's more than a 2-class improvement, functional class improvement, and you can see the consistency of the data. Somewhat similar in the TRI-REPAIR trial. We didn't see as much, and this is maybe the difference between US and Europe in terms of how the test was applied and administered. There was a change in KCCQ score, but not as much. More of a change in 6-minute walk tests. And also people are beginning to look at edema thresholds, although I will tell you that the measurement of edema is very, very confusing to most people, and it's usually all or none, better or worse, and there are not many objective parameters, although some have been proposed. A lot of other endpoints have been suggested for TR studies, but patient variability and lack of validation have relegated many of these ancillary measures as interesting secondary endpoints that are worthy of assessment. BNP is certainly one of them. It's been a fairly reliable biomarker for right heart failure. It has not been a reliable biomarker for right heart failure studies, either as it relates to disease severity or changes associated with clinical benefit. So the idea of using BNP is interesting, but I would not currently apply it as a meaningful clinical endpoint, although I would measure it. We talked about edema and ascites measurements, difficult to quantitate. Things like LFTs, renal function, diuretic use, all should be measured, but they're really not, they don't rise to the level as being meaningful primary or secondary endpoints. As we're talking about endpoints, we really have to, even before we deal with effectiveness, we've got to deal with the issue of safety. And there needs to be a primary safety endpoint in all of these clinical trials. Unfortunately, powered operational performance goals are difficult right now because we don't have very much predicate data to define acceptable safety. So this may be challenging, and we tend to apply relatively broad margins. which are okay, but you have to take this with a little bit of a grain of salt. Some of the things that we look for are access site complications, chamber perforation, conduction disturbances, heart block, worsening stenosis or regurgitation, which can happen. It was discussed earlier today, issues relating to the right coronary artery, either stenosis, occlusion, or perforation. We've seen all of those. And other device-related effects like malplacement, migration, including anchor pullouts, and thrombosis. A composite 30-day safety endpoint should also include death, stroke, acute kidney injury, and repeat intervention, either surgery or transcatheter. So it is essential to have a safety endpoint in these clinical trials. So where do we stand with a primary effectiveness endpoint? To satisfy requirements for a randomized FDA pivotal approval study, there's no single clinical endpoint which would fulfill what I would describe as suitability criteria, which means that it would be clinically meaningful with a predictable event rate, with a reasonable sample size, and a duration follow-up that would be less than many, many years. Therefore, most people have gone to composite endpoints, which is the most realistic approach, including some hard clinical endpoints, and then some softer functional outcomes, and maybe even some surrogate endpoints. When you talk about surrogate endpoints, it's important to note they've got to be quantifiable, they've got to be adjudicated by core labs, and they can't be discordant with the hard clinical endpoints. The composite can be either non-hierarchical, which is more conventional, like what was done in the MITRA-FR study, which was death or hospitalizations, or in many of the TAVR studies, or it can be hierarchical with novel methods, such as what's called multiple pairwise comparisons with either Finkelstein-Schoenfeld or win ratio methodologies that help you to increase the power and reduce sample size. So as an example, if you incorporated death, hospitalization, and this is in a hierarchical fashion, 6-minute walk distance or change from baseline, and KCCQ scores or changes from baseline, that would be an interesting composite endpoint that could be included in clinical trials. Now, if the results are dominated by just the lowest level of that hierarchy, which might be, for instance, KCCQ scores, and you saw no trends that are concordant with those findings in the higher hierarchical endpoints, that would be problematic in interpretation. And I would say that since TR trials are breaking new ground, there should be room for negotiation and creativity with respect to control therapies. People are using adaptive designs for sample size adjustments and Bayesian methods. And you also can consider this very interesting new breakthrough device designation to facilitate FDA approval pathways, which some people are doing. So final thoughts, there's no single compelling endpoint for TR trials that are easily identifiable given the constraints of study methods and FDA approval requirements and our current state of knowledge of TR and the current state of development of transcatheter therapies. Safety endpoints are highly valued when assessing new therapies for unexplored indications like TR, so they have to be incorporated. TR reduction is assumed and should be incorporated somehow as a secondary endpoint with an echo core lab. The emergence of functional clinical endpoints has to be considered. A composite primary effectiveness endpoint should change clinical practice if the outcomes are sufficiently compelling, which means they're highly significant, and the components of the composite endpoint are concordant. So we have a lot of excitement. We saw a lot of new devices being suggested, and I think there is not just renewed, but there's sincere and meaningful interest in trying to treat tricuspid regurgitation and understand the best approach to doing this in a staged fashion. It's been our impression. If you've seen the new app that's been released over the past 2 days, sometimes reality is cruel, and it takes time to be able to develop these things. I think we need to stay the course. The transcatheter tricuspid therapy is coming, but it's going to take some time. It should be done in progressive stages and with the challenge of managing uncertainty and the expectations of mid-course adjustments. But certainly the TR revolution, or TR therapy revolution, is coming. Thank you.
Thinking through all that, Paul, as you now have essentially getting off the ground a randomized clinical trial, the first one in TR therapy. What were your hesitations about picking as the control a controlled trial like that where patients are randomized to staying on their diuretics, essentially not doing anything for them, given that the challenges of enrollment and all the other things here. Can you share your
Well,
struggles?
we just didn't know, I mean, there was just no other option that's out there besides medical therapy. Otherwise, I think what you may be asking is, well, why didn't we consider designing TriClip to be randomization against surgery? Because that's the other arm possibility. And I think for a lot of these patients, we just felt that the risk proposition was too high, just because of the known, at least currently known surgical mortality from a national inpatient sample, among other studies. And so when we were designing the pivotal, and it wasn't just my decision, but it was a huge input from the steering committee, we had a lot of discussions, and we knew it just had to be medical therapy. And what that standard was is open for debate. We've already talked about that, but that's what we concluded. So.
I think, for the eligibility committee, I mean, we do have to have the agreement from the surgeons that, these are very, very high-risk patients, and most surgeons don't argue a lot about the patients that we end up seeing.
Yeah, I mean, at least in the pivotal trial, the FDA did agree to allow us to treat patients who simply were not low risk. So, because that's the other thing we struggled with, was deciding what would be the entry criteria. If you look at, Marty was the pioneer in this. The TAVR trials started off in the most extreme risk, and they marched down in terms of risk. And but here in the pivotal Triluminate study, it's going to be intermediate or higher. And so those would be patients who will be in the study, which is quite nice because it makes the identification, risk stratification, and selection that much easier of putting them in the trial.
Is there any patients that are low risk with TR?
Well, so that's, and I think that's a great one. I think Becky has brought that up quite a few times on the calls. But as Gaurav showed earlier, there are risk scores that you can use to identify patients who are low risk, and we're trying to avoid somebody who is very young who could have therapy, TR treated in different ways, but you're absolutely right. I'm not sure I know what a low-risk, severe TR patient is. I'm not entirely sure. So if they're symptomatic and the RV is dilated, I'm not sure.
All right, so our last speaker of this was Saibal Kar. Due to logistic reasons, unfortunately, he could not make it here. So, and he was to talk to us about, will there be a standalone TR therapy? Meaning, really, is there going to be just one device ultimately that's needed, or do you need a combination? So for make up for that, I was going to ask my colleagues here on the panel if they can answer the same question. Knowing the physiology, as we barely do, of the RV and the tricuspid valve, is one therapy alone enough? Becky?
So obviously there's just no way that one therapy alone. I mean, we know already that there are two kind of general morphologies that we're talking about. There's the kind of idiopathic tricuspid regurg morphology, where there's mainly dilatation of the annulus, not as much tethering. RV shape and function still pretty good. Those are great for annular devices. But then you've got the patients where even a surgeon would say we need to replace this valve, that have markedly tethered, that have RV dilatation, reduced function. I mean, those we just know already that an annular device isn't going to work. We know that surgically that they don't work. And so there's no way that we can have a single device because we have these different morphologies that have come to us with tricuspid regurg.
And so, Paul, how's that going to work for those types of patients that you're going to want to do more than one device? You've got a Cardioband that takes you 4 to 6 hours, and then you're going to go do a clip in the middle on top of that?
Well, I was hoping, hearing your experience with Cardioband, that you're going to solve it for us to where we can do it in under an hour, and then offer some type of other technology. But I think if I could offer a buzzword, I think all of these technologies have to be somewhat permissive. So in other words, the nice thing about Cardioband and the other annuloplasty devices that have been discussed is that it doesn't burn bridges, and in fact, it could potentially enhance other therapies with perhaps serving as a platform to either bring the leaflets closer together to make them easier to treat with Pascal or MitraClip, or even serve as a landing zone for replacement technologies down the line. I think there are certain other therapies that make the future therapies a little more challenging. So if you were to start with MitraClip and Pascal, for instance, I know a lot of people know about our clip cutting experience, which actually I'll show in the next session. That bridge can be addressed, but it just makes it more difficult in clinical practice. So I think as long as these therapies are permissive, I don't know if it matters what sequence they're done.
But I certainly think there are going to be some patients that could be managed with a single therapy. I mean, if you listen to Steve, again, it's a rigid ring. It's 10 o'clock to 6 o'clock. It's, 10 sutures, 10 minutes. And that's the way every operation should be done. And clearly, many of these patients do get a durable benefit. So I do think that either, a leaflet gathering procedure or a more definitive annuloplasty repair, can be a sole therapy. But there'll be a significant minority of patients that won't get enough benefit from a single procedure. And then I think sequential procedures are going to be very interesting in this space. And I think you can design it into clinical trials. If you look at the revised version of the Carillon trial on the mitral side, they've now allowed that if patients don't achieve in either arm, because it's a sham-controlled study, and patient doesn't know what they've gotten, if they haven't achieved clinical benefit and MR reduction, that an independent group can say that that patient can have a MitraClip, at some point in time, 6 months after.
Is that a negative endpoint then, Marty?
It's a negative endpoint.
Negative endpoint.
Yes,
yeah.
on either side.
Either side, yeah.
On the control side or on the therapy side. So I think there are ways to begin to creatively build this into a clinical trial design to account for the need in some patients for multiple therapies to get an adequate clinical and a TR reduction result.
So in pivotal, if you end up having TR surgery in either arm, it's a negative endpoint as well. And so that's important because, when you're randomizing these patients, we can't take away all their options. And then actually at a year, you can cross over. So if you need to.
Yeah, in the same way, I think one of the impressive COAPT findings was the change in LVAD and heart transplant rates. So I think that those kinds of things need to be incorporated as well.
I mean, listening to your talk, Marty, I feel like we just need one trial to get going and inform us for the other trials, because there's a lot of unknowns. I mean, we're extrapolating so much from the left side to the right side, whether it's KCCQ or even NYHA. It's not really a right-sided functional class system. So we're extrapolating so much, and I feel like the pivotal trial just needs to start and give us the data to kind of inform the future studies. Would you agree with that? Or? Absolutely,
and I think that, there's no question, I think it's a combination of safety and operator confidence that the MitraClip and at some point in the future, perhaps Pascal devices will be the first ones that will enter pivotal clinical trials. They clearly are. And I think there'll be a density of data with those studies. I'm sure there'll be over 1,000 patients treated ultimately, where in the next several years, we're going to have meaningful randomized data that, in a defined patient population that we can characterize. And I think that's going to have a big impact on further studies down the line. But many of the other devices are not ready. They are not ready. They haven't passed, as far as I'm concerned, the safety threshold. And there may be some extreme circumstances where valve replacement may be necessary in certain patients, but to propose that as a general therapy for severe TR at this stage, it's too soon.